जाओ ना अपना दिन 6:30.
Shall we proceed? Yes.
So we'll make you a co-host for you to share your screen. Uh,
So no, I think today is just about everyone else presenting. I'm just going to be facilitating the discussion. I'm
oh,
not really presenting anything
okay,
much.
okay, sure.
Just to highlight that what you said is, even though we work for many years, we all still benefit from reflecting. We all have in the UK, every 6 weeks, we have a supervision session where we reflect on our cases with a clinical psychologist who's our counseling supervisor. And there's so much benefit from it. There's so much we learn from it. And we often come across challenges that, sometimes can throw us in clinic or tell us, we don't really know the best way to approach them at that time. And that's how then we learn by reflecting on such cases with a team, or colleagues, or a supervisor. What went well, what were we feeling, what we were thinking, what was happening for the patient, what could I have done differently, and what went well as well. Because if there's something that we've done, very well according to us, we need to hold on to that and grow with that. And cancer genetic counseling is not, just about genes and race and figures. It's a lot more. We have, a lot of patients who come to us are quite vulnerable and are going through probably the most difficult time in their life, or they've been through difficulties with their family. And so there's a lot of emotions, there's a lot of layers involved in their decision making. So our role is also to kind of tease out those emotions and those thought processes to make sure they're making an informed decision, sorry. So what I'm really looking forward to from our discussions today, firstly, there's no right or wrong. This is not, to say whether someone did a good job or a bad job. It's just, to learn from each other and to explore where our strengths lies and where there is, if there is any room for improvement, what makes us comfortable, what makes us uncomfortable, and just to kind of have a informal discussion. So I'm really looking forward to hearing it. How many cases do we have today? Is it five or four or six, or how many people are presenting today?
Yeah, one of you please speak. बोला है ना present करने को? No one is saying anything. Hello.
Hello,
Good
good
any?
evening. Good evening, sir.
Yeah.
Hello, hi, Areeba, ma'am. I think it's morning over there. I have one case. I'll be presenting one case. I guess a few other batchmate of mine also have few cases.
Okay. So let's get started then. So maybe you all can present your case, and then we can have a discussion after that, before we move on to the next one. So we
Okay.
give enough time to everyone to share and then reflect on things. Is that okay?
Yeah, that's fine. So, Fatna, very briefly tell us about your background before you joined this course few months ago. What kind of experience you had?
Okay, so I've graduated with biotechnology background, master's, and along with that, I've done one diploma in clinical research, where basic studies. And then after that, I have worked for 5 years with a company named Positive Bioscience. It was a startup. They have a collaboration with Myriad. So all the Myriad cases from India used to go to US via us. And beside that, uh, COVID and everything happened with Positive Bioscience. So I got little exposure to genetic counseling during the COVID period. Uh, Post that, I joined One Cell Diagnostics and was there with them for a few months. But then I was thinking that maybe for 5 years, I had done rigorously reporting for various cancer types. I was thinking maybe I should try something new. So then I took a break. And for a little while, I was associated with my own college. as a associate
Okay.
professor. And
So
after that,
counseling
I joined.
experience, yeah, that's all right. So counseling experience mainly you learned here, few months of
Yes,
experience.
yes.
So when we
I
see what you tell, that is also based on how much of experience you have, because that also depends. So a seasoned genetic counselor who has counseled maybe hundreds or thousands of cases, the way they will look at it is different. But as Areeba said, your approach right from the beginning, if someone can help you getting the right approach, then your
hmm.
learning would be faster. You will make less errors and your patient would benefit more. And as she said, we are not judgmental, but still maybe we can suggest a different way. Or most important, as she said, what is good? If you identify, that will be very important that you can grow on that and, help people. Ariba, one thing, another thing I want to say, I've learned many genetic counselors learn from each other. So in the
Mm-hmm.
beginning, they come, I can see all of them have some strengths over a period of time. They tend to imbibe good things and they appreciate the good things in others and they would wish.
Yeah.
So you have also seen that?
Yes, absolutely. In fact, when we often do reflections, we do it as a group, along with the supervisor, and each one of us can give comments, or our observation of the case discussions and things, and we definitely take very you know with a lot of gratefulness what each other advise. And like for example, I was not very well versed with assessing capacity for someone who has learning difficulties, or or has any neurocognitive decline. And there is one of my colleagues who's had more experience in that. So when I first had a patient, who I needed to do that for, I invited her into my clinic, and kind of she showed me the ropes. And now that's something I feel very confident about. So we obviously definitely learn from each other, and we recognize each other's strengths, and that's what today is also about. Just giving each other guidance and tips and tricks, and learning from each other. Right. So who's going first?
I think Fatma will start with her case.
Okay.
Okay, sir. Thank you. Uh, I cannot see the option of presenting. Can I or should I
Yeah.
just start
No,
with the?
no, we will allow you, we will make you, कैसे करते हैं? Make co-host. Okay, so now you will be able to present. And others who are going to present, please message Anchal. She will make you all the co-hosts so that when your turn comes, you can present.
Okay. I hope my screen is visible.
Yeah.
Can you make it full screen if possible?
Yeah, yeah. 1 minute. I'll just try it out. Okay. So this is one of my reflective cases for today. Uh, the case, I am sorry for the pedigree. I'm very new to genetic counseling and drawing pedigrees. So here, there is consanguinity in the family, and our proband is here. He's a 34 years old male, and he has been diagnosed with CA rectum at at the age of 31 years, and he had MMR proficient tumor. In somatic findings, we had find a TP53 variant at 5% VAF. At that, after his treatment and everything at TMH, he was disease free for almost 3 years, 3 to 4 years. And post on follow up, it was found that he has lesion in presacral region, and in the year 2025. And again, the lesion was MMR proficient, and he had to undergo prostatectomy and various other lot of therapies again. And then in the year 2025, he came to us when he was 34 years old. So he came during pre-test counseling because he was sent to us because he had cancer diagnosis at a quite young age, and he had a recurrence. So we like a quite fit criteria for undergoing a genetic testing. So when he came, he was accompanied by his father and his brother. Before starting with the pre-test, I asked him whether he's comfortable being alone or he wants someone beside him. So he said no, he's okay. He wants his brother to be with him. Then we started with the pre-test counseling. We explained everything. We started drawing the pedigree for him, and then later on he was not able to explain the consanguinity in the family. So the father came, pitched in, helped with understanding the consanguinity. And post that, after this is all about pre-test, the main genetic part. Then psychosocial issues, when I gave him some time to speak alone with me.
Sorry,
As
can I just ask, what pre-test were you doing? Was it the entire hereditary cancer panel? What were you offering him as a test?
we have a panel of we have a panel of 84 genes because his tumor was MMR proficient. So the broader panel, I
Okay.
gave him the option for that. Okay. So, majorly over here I felt little, I became little uncertain with the respect to the psychosocial issues which came when I spoke to him separately. With his brother and with his father, he was very confident and he was very positive, like with respect to his treatment and everything. He was like he'll get through it. And once the father and the brother stepped out of the clinic and he was allowed given the space to talk openly about just himself and how he's managing the disease. So he explained that he, as a profession, he does embroidery, zari work on bridal dresses. And so he had a long dream or desire to make one of those dresses for his to be bride. And when he was diagnosed at the age of 31 with CA rectum, he basically was planning to get married. But since his diagnosis came and the treatment was long, so he gave up on that idea and he was like, I'll look after myself first and then I'll think about the marriage. And then again, when everything went disease free for so many years, not so many, like few years, so he again started thinking about the marriage part because he was really looking up for marriage. So then post that again he got a recurrence, and now because of prostatectomy and his he also mentioned that he was given the option of fertility preservation, sperm banking, but he opted out of it because of the cultural thing that from the background he comes from. And so he said that thing is out of my life now. Now I cannot, get married and I cannot have kids. And I have lot of, I had that desire for long, long, and I'm not able to fulfill because of this disease. So, and so I gave him an ear, I listened to him, and then I had, at a particular time point, I didn't had anything else to say. So, because I have seen a lot of cases where,
Just to highlight that what you said is, even though we work for many years, we all still benefit from reflecting. We all have in the UK every with a
I think
clinical
someone's
psychologist who's a
YouTube, someone
counseling
is playing
supervisor, and
YouTube on their.
there's so much benefit from it.
hello.
So, did you want to say something, or that's how the
No, no, I
brain
think
works
something
by
get got
reflecting
started. Someone's
on
YouTube
such
recording is
cases
playing.
with
Just
a
one
team
second.
of colleagues.
Hello, Miss Areeba, I can't hear you.
Yeah, I'm just waiting to hear if
Okay,
Sir had to
okay.
comment, or perhaps you can proceed and then Sir can add on, when the background noise is resolved.
You were saying something, I didn't hear you properly.
Um, Proceed, it will come back to me.
Okay, okay, okay. Sorry, due to technical issues, maybe because of that. Okay, so this is the case. So this thing happened during pre-test, and I was little, uncertain how to, counsel this person
Mm,
for the head. So I took help of my batchmate Aloysius. I asked him to pitch in and to make him understand that it's okay, he will recover, and he can look at the positive aspect of his life. And but when I called Aloysius, he got little apprehended. He stopped talking all of a sudden. The way he was talking or communicating to me, he completely shut off. And then he just told me that I had not told this thing to anyone else. I just opened up to you and I said this thing. So I felt really bad that instead of calling Aloysius, I should have sat and I should have given him the space and time to, feel what he was feeling and just to be there. So that is
mm,
what one of the thing that I have understood, that me generally if a female patient is there and if there is a language barrier, so we take other GCs for help, and that has in other cases have proven beneficial. Like people generally female feel more comfortable and they like to talk about it.
mm,
But perhaps that is not the scenario with the male patients. They think differently and they generally do not talk about their emotion very openly.
mm,
So that is what I have learned about from this thing, from this case. And next time, if any patient talk or opens up about things which he has not shared with any other person, so I would ensure that I give him like time and be there and listen, even though I don't have any right words to assure him or help him
mm,
in any way. I think hearing
mm,
out plays a major role.
mm. Um, this is a very interesting case that you've brought up, and there's a lot of things that are coming to my mind. So let me kind of try and help break them down a bit. So, the first thing is, it's very nice that you recognize that your patient was uncomfortable, or perhaps he was not making the was not really focused on the genetic testing and was not able to kind of reflect on that to you. For people who may have not had that experience, can you share what kind of things you noticed during the session that helped you pick that out, um, for your patient?
I think his uh, body language, demeanor, the way he was like, I could understand he was trying to show a brave face towards his family.
Mm,
And when his family member stepped out of the clinic, he was
mm,
the facial expression, body language, they kind of little
mm.
soften up, and then he was talking a bit more when comparatively when his family members were there. So that
And,
helped.
and and how did you get them to kind of give him the space and leave the room? Because I feel like when I was starting out as a genetic counselor, one of the things that I really had to work on was to ask family members to leave the room or give us space for one-on-one. Especially, in India, culturally, families are quite close, and sometimes people may take it as an offense when you ask them to, leave the room. So, how did you manage to get them, and how was the feedback that you got from them?
Yeah, I understand that happens with a few of families, but here the family members were the thing is his brothers and were educated, they were engineers and they were
Mm,
working well, and
mm,
so they understood everything, so they didn't hesitated or they didn't feel offended for when I asked them to step out. I said I need 5 minutes with him.
mm,
He also mentioned that he never had any interest in studying, so he never perceived, and that is why he
mm,
went into that
Okay.
embroidery thing. Yeah.
Now,
Yes,
I was
if I
also.
add,
Yeah.
Ariba, I will add one thing. So this
Mm-hmm.
is very important point that talking to the patient or the fam or that individual alone. So I think we have been saying that this is important. Somehow in the last 1 or 2 years, our genetic counselors have developed the knack or some technique that almost for every patient they manage to speak to that person alone also for some time. And
Mm-hmm. That's
same
clever.
way, so I think it has now become like a cultural practice. As you mentioned earlier, when you were doing many times it is difficult, but
Mm.
I don't know what they do, but they manage to, get
Yeah.
the time with almost all of those who come for pre-test counseling.
I think it's really, what, when you are sitting across the table, if you feel like they're communicating well, there's no external factors influencing your patient's decision, and the family members actually they're in a supporting role. I think, from my experience, it's fine if you don't have that one-to-one, if your patient is opening up and there's no hesitation. But if you feel like for example, in this case, Fatima felt that he's not really being open, he's not expressing himself well, then in those cases, definitely yes, one to one is helpful. But in some cases, the patient might need the other person's support to be around, and to be able to open up, and in some cases, also contribute to how they feel and kind of what they say in some cases, and how they are able to cope and manage with things. So it's kind of a balance, and how you perceive in that situation. It's not always that I have to have that one to one with the patient. It just depends on the patient's need. Would you agree with that, sir?
I think that's one thing I missed. How come, in between our this thing started playing up. So how was Aloysius sort of came in because of the mail? We couldn't hear all of us what you said in those 1 or 2 minutes.
Because he's a young
Okay.
person and male, and he was not initially opening up to me. So
Uh,
when he said all of these things, so I thought maybe, as a female, we have that if a female is, there in front
yeah,
of us, we
yeah,
feel
she
more
said that.
comfortable to talk.
Yeah,
So
okay.
with
That is
that
all.
mindset, I called Aloysius to help.
And you wanted him to be alone with Aloysius so that maybe he will share.
Maybe he might open up something else, or he may feel more comfortable sharing it.
See, the other thing is the medical history. So what he had a life-changing operation. He had a permanent colostomy,
Hmm.
APR and colostomy. So, at a young man, if he has something like that, it would have affected him very badly. So the colostomy bag and the
Hmm.
surgery which he had, even the abdominoperineal resection and prostatectomy, most likely he would have become impotent. That means erectile impotence. So these are also things which may be playing up on his mind. So this is from the medical back, consequences of his previous treatment, that part.
Um, Fatima, you spoke a lot about his psychosocial um, circumstances with respect to his career or his desires for marriage, and it sounds like you spent a lot of time on that. What about his thoughts and feelings about the genetic test? How did he perceive, or what did he think about having the test? Did he think about whether there was any benefit, or did he just think that it's something I have to do because I've been asked to do it by the doctors, or kind of what was his reason or motivation to go ahead with testing? What did you think about all of that through the discussion?
Initially, he because he was not opening up. He said that he's just undergoing the test because the doctor had said so. But
Mm,
later on, he when he understood that what genetics is and what were how these findings can help him and his family. So he was like, yes, I want to go ahead with it,
mm,
and like thinking, I don't know what his mind was about, and then he agreed. And later on, in when we did post counseling for him, it was a
mm,
virtual session because he's going to visit TMH after a few more months. So
mm,
he requested for a virtual counseling. We did it. I did it with Gopa. And
Mm,
in that post test, seeing the results that there is an incidental finding with WRN gene and VOS in PDGFRA. So he was still, he himself, he came up with this thing that seeing the reports and the finding as you have explained, I am still not into the marriage thing. We didn't
mm,
put up the point because we knew that it is a sensitive thing for him.
mm,
So maybe back of his mind, he was thinking about, maybe, I'm not sure because he didn't precisely word it. So uh, that may, if something benign report might have come, so he might have thought about it, or I don't know, because any which ways he had never opted for fertility preservation.
mm.
So any which ways it would not affect.
So the thing is, a lot of the times
Hmm.
when patients talk about their personal problems that could be related to how the medical condition is impacting their life,
Hmm.
and they tell us, so, this is what my dreams were, this is what my hopes were, this is how it's impacting. It's very easy for us to get drawn into and get pulled into talking about that aspect. What we need to recognize is that sometimes we have to be very mindful of what is our role and our responsibility at that time. Yes, we have, obviously we listen to give them some time to explore their feelings and what's happening in their life at that time and how things are impacting. But after a certain point, we are not trained to give them that psychosocial or the clinical counseling for certain things that they're going through, like for example how his disease is impacting his life and future life.
Correct.
um so did you ever think about referring him for counseling support to cope with that at all?
I have requested him to, whenever he visit TMH again, uh,
mm,
to visit us, to visit CGC again, and to go
mm,
undergo
mm,
in-person counseling with
mm.
us, so that if any doubts or anything he has not understood, so we can reiterate to him.
No, I'm talking about the counseling support for his mental health and his
No,
impact of the
I
cancer on his. So
no.
sometimes, because so it looks like his main problem or the main concern that he had is
Mm-hmm.
how the cancer diagnosis has impacted his dreams
Mm-hmm.
of his future life, what it looks like, and his the treatment he's had, like Sir said, it impacted his future to have a family in a way. And those are the issues that are persistent in his life, and hereditary cancer risk and genetic testing was probably not at the forefront of his mind. So, one of the things for us is to recognize sometimes people will have issues that need to be dealt with to help them move forward or give them the strength to kind of move ahead from that and cope with the situation they are at. And therefore sometimes we need to recommend them to have counseling support that is not genetic counseling, so that they can get support the way they need in that time frame. The other thing that I wanted to ask you is, how confident were you that he was making an informed decision about genetic testing in after your appointment? Because it looks like you spend a lot of time talking about his marriage dreams and his work and all of that. But did you also spend a substantial amount of time talking about genetic testing and the outcomes and how that might impact his future and his family and things?
Yes, definitely. The first major half of my session went explaining genetics to him,
Mm,
and he understood everything. And
mm,
in later part of the session, I just gave him time to speak about the
yeah.
issues. So
And how
yeah.
much how much do you think um his issues, apart, like not thinking about genetics and future risks, but his issues, how much do you think that was factoring into his ability to make an informed decision? Was it factoring at all, or did you think it was not impacting that, or how did you feel that kind of built into it, your decision making or his decision making?
So initially, as I said, I first question I asked him that your understanding about genetics and why are you here, why you want to do this test.
Mm,
So he answered very simply, stating that I'm here because my doctor has referred me to do this test.
mm,
Post explaining the genetics and showing him his own family tree, and this is why we are doing this test for you. Are you wanting to go ahead? So
mm,
he agreed to it. Then I explained the consent form also to him, and
mm.
then he signed it. So
And did you explicitly ask him like what his motivation for having the test was? Like, why is it that he wants to have the test? Because sometimes the patients might tell us that, they understand things and they want to go ahead, but
hmm,
we need to sometimes ask them specific questions to assess whether they've actually understood. And one of the ways I find it is helpful is to ask them why they want to have the test, and that answer can give you a very good understanding of whether they've really understood or are they just going along with things. So have you ever asked that question in your clinic sessions, not in specifically this case or any other cases, and what has been your experience
yeah,
with that?
after explaining why
Mm,
we are doing the test for you and explaining the consent form, I before they signing in, I asked them to explain what I've explained them to,
mm,
like a recall method.
yeah.
So I asked them for this person also and for other patients also. I asked them, and most of my cases, like they are able to give me an appropriate answer.
Mm.
Not exact terms, but they have understood the
Obviously, yeah.
genetics, the risk. Yeah.
So maybe next time you can also try asking if they've decided to go ahead with tests. Try and see what kind of different outputs you get is about why they want to have the test. And most often than not, people will say because I want to know my risk or I want to help my family or etc. etc. But at least like if someone says I want to help my family, then they've understood that it will have implications for they've understood that it have implications for their family. So sometimes getting them to kind of summarize what you've said can be quite challenging for some people, and they might be able to put words better into why they've made that decision. So
Hmm.
maybe you can try that and see how that helps you at all. And I think you've done a really wonderful job with this. It sounds like it was quite challenging, and we have we tend to use when a set of kind of criteria when we see a patient. Is that patient is a patient a client? Is it someone who's interested in what we are offering them? Is the patient a complainant? Like, are they just coming because someone has asked them to come and they have no interest in kind of what they want, or and they might find some issues with what we're saying or doing? Or is someone just a visitor who will just come to explore kind of what we have to offer? So it sounds like this patient was a visitor, and you kind of through your counseling um, moved him towards being a client and giving informed consent. So that's sometimes that can be quite challenging as well. So that wonderful, well done. And if I were to ask you what is your take home, you did mention about the having another person in the room for counseling, but with regards to your counseling approach, was there anything that you identified that you liked, or anything you want to work on, or anything you thought that you should not do again? Do you have any kind of those insights to offer us before we move on to the next one?
Firstly, I would like to. I was happy that I gave him that space to talk separately away from his family. So
Mm,
I understood that it is very important. At least few minutes we should try.
yeah.
We should get with every patient few minutes alone, and
Mm,
then the part where I became very underconfident when he opened up about his dream and desires of marriage, and then I, because this was my one of first such case, and
mm,
so I was little jumbled with the words, like right words were not coming out. So
mm.
then that
So
time
what
I
specifically about it made you uncomfortable? Were you able to recognize that?
what made me uncomfortable, because I made him speak. I gave him that space and platform to talk about it. But then later on, when he opened up and he said all of these things, and then he himself had most of the answers that, I cannot do this, I cannot do that. So
Mm,
at that time, I didn't realize that I just had to, take a back, give him the space to be with his emotion. Instead, I
mm,
called Aloysius, and then he felt offended that, I told you, and then you have called another guy and you are making me speak to him. He didn't put
mm,
it to words, but with his, he completely shut down himself. So that is what I've understood. So in my next cases, if anything, any patient comes up and says something like this, so instead, I may ask my other GCs, but very, at a later stage, if I will
mm,
try and I'll give them, if the rapport is built correctly,
mm,
so I'll give
mm.
them the space to be themselves for a while.
And what kind of response do you think you might give, to a similar situation, in the future? Like, if you're not going to invite someone else in, what have you thought about what kind of responses you might come up with?
The response as in I have thought that if the same scenario comes up, I would be
Mm,
saying that with the ongoing treatment, your health will get better. And
mm,
like previously, how your cancer was treated and you were back to good health. So maybe now also, with if you do the proper workup as doctors are saying, so you will get better. So
mm.
kind words maybe.
Yeah, but we also have to make sure that, we have to recognize that not all of us are medical professionals, and, sometimes we don't recognize the depth, or, the severity of their
Yes, and also as you
diagnosis, and
mentioned
we
that
don't
to
have to
refer
give
them
them the,
to
yeah,
help
and
for
yes, yeah,
coping
so
mechanisms. So that
yeah, yeah. So I just wanted to highlight that, just be mindful of not giving them false reassurance, because we have to recognize sometimes, we can tend to give reassurance to a patient because we want to feel better about their situation, or because we want them to feel better. But if it's given in a situation where actually things are quite difficult and may not take the best turn, then that
mm,
can also be harmful to the patient. So we have to really recognize, are we doing this in clinic for us or
mm,
for the patient? Are we doing it to make someone feel better? What is it? Is it okay to do this act or say this? Because we all want to make people feel better. That's an innate,
yeah, not to
quality
give
that
them
we have.
false hope,
Yeah,
basically.
yeah, exactly. So did you have anything to add, anything to ask before we move on to the
Uh,
next?
I don't have to, just one point which you said, Ariba, which was very important, that asking them for understanding what is their motivation for doing the genetic test. And this was a pre-test counseling session before they, agree for counseling. Even before disclosure of results. So what we do is made a protocol that when they come for post-test counseling, this first is the first thing we start with, that do you remember why this test was suggested and why you agreed to do this test, so that we know it. And most of them are able to actually recall. Their occasional case patient who is unable to remember or recall. Not only they remember, they recall and they tell us. And for their family, the two things that they say. So Fatima, do you know what are the two things most patients, when we ask them why do you remember why this test was done? What are the two things most patients say who have undergone genetic testing and today come for the results and post-test counseling
Their chances of recurrence and for their family.
for the family? And some of them also say for the treatment,
Yeah,
because
for
the treatment
treatment,
will be
yeah.
decided by. Yeah, that's all I had to say. Very important point in this case, what Ariba, as an experienced genetic counselor, said, and knowing how the socio-cultural milieu, many genetic counselors, especially those who haven't had a lot of this thing, they get carried away by the emotional story and saga, and then you can do that, but in the process, do not compromise on the main reason why that patient is seeing a genetic counselor before a genetic test is ordered. So that part has to be done no matter what else. And then whatever else, of course, you have to see, understand what their vulnerabilities, what is making them feeling insecure, etc., etc. But that aspect should not cloud or overshadow your main, professional reason why this person is, I would say, one of the main reasons. That's not the only reason.
Yeah, and sometimes, that it like, we have to, yes, we have to identify what we can get into and what we can't as per our role.
Yeah.
But sometimes it's equally important to know, because it may not be the right time for that person to have the genetic test if they're going through a very difficult and challenging emotional time, if they're not going to be able to cope with a mutation positive result. And especially, it gets more challenging if the person's test result is going to impact their treatment and you feel like emotionally they're not in the right space. So then you might want to offer them, I don't know how much capacity you all have, but sometimes we tend to offer them another appointment in a few days' time to kind of see how, if they're feeling any better with what you've discussed, because we also have a professional responsibility to make sure we're not doing any harm to the patient. And if you're testing someone who's going to not be able to cope with the result very well, or if a positive mutation positive result is going to impact them, and lead to depression or taking any rash decisions, then that is also not a good situation to be in. um, right. So the next, who's presenting next?
I'll just, Ariba, I will add one point. So this is a traditional approach, but as you know now in the UK and everywhere, for everyone is going towards mainstreaming because the number of patients, number of conditions for which universal genetic testing is required. I mean, there's no way any genetics clinic can cope with that number. So for some of conditions like ovarian cancer, even in absence of family history, 1 in 6 would turn out to be having a germline mutation in a high penetrance gene. So all those things in the clinic, these things are routinely overruled. I mean, the
Mm.
clinicians, they just know they have a FAQs, okay, genetic test is indicated, and they tell them if you find something, we will book a genetic clinic appointment. So have you seen that in your experience?
Yes, I have. I mean, so there are sometimes very rare, I've had patients who've had mainstream testing and have come and they've not really, I felt they've not really understood what they've been tested for, and, kind of what the whole basis of doing the whole thing, the impact on family members. Most often, people will have a brief understanding that this is for future risk and my family, but sometimes it does impact their mental health quite a lot, and they find it difficult to cope with if it's not, you know, something that has been explored in the pre-test counseling. So we do actively as a department also kind of help train a lot of professionals who are doing mainstream
Yeah.
testing and kind of helping them pick out. But it is challenging, like, for people who are doing mainstream testing, they're doing the, discussion about the cancer, the treatment, and on top of that, to expect them to have a 45-minute discussion about genetic testing is probably a lot to ask from them. So unfortunately, sometimes we have to deal with repercussions, but that's the benefit of being genetic counselors. At least the patients that are coming to us, we can give them that holistic and, of complete care. Um,
Thank you. I think next case we can move on.
Good day, Rajiv sir and Areeba ma'am. I'll be presenting the next case. Could I get access to share? Okay,
One
just a
second.
second.
We'll make you
Yes, yes,
the,
yes. I got access, I
you
think.
got access, no? Yeah.
Is my screen visible?
Not yet. It is, yeah, okay. Visible.
So, this is a case of a 45-year-old male. He was diagnosed with recurrent scrotal epithelioid sarcoma. So I just wanted to paint the scenario. I had actually gone to the ward to visit this patient. So it was an in-ward patient with, and it was a private room. So it was in the room were the proband, his wife, his sister, and his brother-in-law.
mm,
Uh, yeah. So then so as I got the file downstairs in the clinic, I knew that it was the case. I knew the diagnosis, and then after that, I had prepared the case. So it was the histopathology was of suggestive of poorly differentiated carcinoma. Then regarding his treatment details, he had undergone a couple of surgeries, and he had also received radiation therapy and chemotherapy.
Mm.
Uh, he had a positive family history of malignancy, and this is when I went on to the ward and I collected this information. So the pedigree looks like this,
Mm.
where the proband's maternal grandfather had an unknown malignancy at an unknown age. The
Mm.
proband's mother had throat cancer at 60 years, but they were unaware of habits. The
Mm.
proband's sister had succumbed to CA oral cavity with habits. And the proband's daughter, the eldest daughter, is a 16-year-old, is a 17-year-old girl, and she was diagnosed with chronic myeloid leukemia at the age of 16. So this is what the family history is like. Then, so in view of all of this, and also the proband has history of tobacco and alcohol consumption, and is currently reformed. So he was referred to the genetics clinic for genetic counseling and testing due to his personal and family history of cancer. During pre-test counseling, I understood that his main caregivers during the treatment journey have been his wife and his sister, and he's able to closely confide with his wife. But however, he mentioned that he has very little support from his family. So during the pre-test counseling, I was able to procure some of the psychosocial issues that he was experiencing. Firstly, the proband experienced strong fears of mortality. He repeatedly expressed beliefs that he may not survive long enough to receive the genetic test results itself. So he displayed significant anticipatory anxiety and possible depressive symptoms. Then I could gauge a sense of liability on his end, a sense of lowered self worth and esteem. This was caused due to a high cost of treatment related expenses. And he himself is a laborer. He works in a power loom in the cloth industry as a daily wage laborer. So he had low paying income and he was unemployed since the time his treatment journey had begun. The major distress also was regarding his eldest daughter's diagnosis, with concerns around her treatment outcomes and her long-term health. The worries also circulated the future of his other healthy daughter and his son, and as he is the primary bread earner of the family. He also meant so when I spoke to him in private afterwards, he also mentioned that he had body image issues that were because of the recurrent lesions that were coming and the progressive the rapid progression of the disease and plus the size of the tumor. So that was something which he mentioned to me in private. And the proband also displayed a lack of trust in the healthcare system. So this was because at the time of pre-test counseling, his chemotherapy and his radiation therapy plan had been paused or suspended for some time. So he also mentioned that if maybe chemotherapy were to be started earlier, or if the surgical protocol had to be undergone earlier, he probably would have had a better outcome by now. So this was some of the psychosocial issues that I had experienced. And then I went on to explain to him what the test will be, what genes will be testing, what are the three types of outcomes, that is pathogenic report, benign report, or a VUS report. So, ma'am, when the layout that you've provided, the reflective thing, I tried to analyze some of the things and tried to
Mm.
put in those details. So, regarding Egan's skilled helper model, so based on
Mm.
that, regarding the exploration, that is what is going on,
Mm.
I understood that the patient was presenting with severe anticipatory anxiety, fear of
Mm.
death, then
Mm.
guilt and perceived liability.
Mm.
And for this time, when I was talking to him in private, I tried to provide him a little bit of hope and reassurance. This
Mm.
is what I thought he required at that time
Mm.
moment in time.
Mm.
So while I was talking a lot about pathogenicity and types of reports and what the turnaround time would be of the report and all, I understood that maybe talking about some of these issues also is of importance in that period of time.
Mm.
So that is
Mm.
something which I reflected upon. Then stage two regarding understanding. So what do I want instead? So I understood that his something that he wanted to know is what is the cause, because a lot of family members have already succumbed to this
Mm.
to cancer, and his worry for his daughters, the affected daughter as well as the two children that he has.
Mm.
Along with that, I think what do I want instead? I was also thinking of me as a genetic counselor. What did I want from that time? So I wanted to know that if he has understood what I am talking about in the terms of the genetic aspect, did he understand what are we trying to find out? What will we find? What will the types of reports be? And is he ready enough to understand those reports? So that is something that I was also trying to understand during the counseling session. And with regarding to action, I really could not actually at this moment reflect upon that. So yeah, and then regarding the Dan model. So the desire was strong, is what I understood. That is and it was driven by his concern for his individual, his recurrence, as well as for his family members, that is his daughters and his children. The ability could be questionable because of his high anxiety, his depressive like symptoms, if I were to say, and the reasons, basically family members and the need for answers, and the need would be urgent because I would feel that he is thinking that he might have a limited lifespan. So the need would be urgent in that sense. Yeah. So then, as of then, post that, we have found a heterozygous missense VUS in exon 8 of POT1 gene, which is identified. And yeah, the post-test counseling was it went smoothly enough. It was done by a senior genetic counselor. It went smoothly enough. And I saw a lot of complete shift in his mentality during post-test counseling. While during pre-test counseling, he wanted his therapy to start, his chemotherapy or some of that, and he was quite, I mean, he looked quite sad. During post-test counseling, he was happy that his treatment had continued. His treatment has, he has like the tumor that he had, that the size has decreased. So all of his major concerns, he himself told me that I don't have so much of this limited lifespan. That mentality has kind of reduced because his treatment has started. So that was some of the shift in his mentality, may I say, or of his behavior. Although I don't know if 100% if he has understood what a VUS actually means. So this is about the case that I had to present.
Thank you. That was very well presented. And thank you for trying out the Egan's reflection model. How did you find the experience of using that?
It took me some time because it was something new to me. So initially,
Mm,
I was also a bit baffled, like how should I go about this? But then when I actually sat down with a pen and paper, I could
mm,
kind of understand what is expected. So I think this is a really good reflection to think like for future cases. So if
yeah,
in the future, if I deal with certain similar scenarios, I think I could be well equipped, much
yeah,
better equipped. Sorry, not well equipped, but yeah, I think I could have a better outcome next
yeah.
time.
And at one of the points you mentioned you were thinking about when thinking about like what is it that you wanted out
Mhm.
of the session is you wanted to know whether he
Yes.
understood what you explained to him about the test and the implications of it. And did you find anything that gave you that answer at all? And how did you kind of answer that question for yourself? Or was this a after reflective thought that came to your mind?
So the thing what I do during my pre-test counseling is I always
Mm,
ask the proband or the family along with them, what have you understood, and kind of summarize to me what I have told
mm,
you. So in
mm.
that way, I try to gauge if they have understood what I have told them or not. So with that sense, the actually not himself, but the family members were able to recall that there are three types of reports that could be expected, how long
Mm.
the time will be, and what types of yeah, so a little bit about that. So
Yeah,
not in great detail, but they did understand something
yeah.
somewhat.
One of the things that I sometimes find helpful is instead of, directly asking them to summarize what we've said, I tend to ask them how do they feel about the information I've shared, what is coming across their mind, and, what are their thoughts about it all. Because sometimes I found that when I used to ask people to summarize things, they might sometimes feel like they're on the spot and they have to say the right things, or they might feel pressure that to use sometimes jargon terms, or but if we kind of frame, essentially we're asking them a similar thing, but if framing the question slightly differently, that also tells us rather than that just what they remember they heard, kind of what they're taking from that information. I'm not sure if you ever tried that approach at all, Aloysius.
No, I haven't tried that.
Maybe if you think that's a good idea, maybe try that and
Correct.
see whether you get a different response, because essentially what do we want? We want to make sure that they've understood it and they understand the implications of that test for them, and for their family. And I think by asking them about how they feel about it also incorporates the psychosocial aspects. And like, yes, you recognize that he is has he's anxious about his treatment, and he has all these psychosocial issues around his family and his daughters and things. But how does all that impact his ability to make a decision about testing, and how does he feel a positive genetic test result, where you find a mutation, is going to impact and add to all of that. um, so I think sometimes it might be helpful to use that approach to really kind of tease out what exactly is it that they're looking for from this test, and is that really going to be beneficial for them at the time and their family, and as a family how they're going to cope with that information. Because looks like they've dealt with a lot, they're dealing with a lot in the situation, and if there was an added high risk mutation that was found, um how would that have changed the family dynamics? How would have that impacted his sister, his wife? Would they be more upset? Would they be more concerned? And if they would be, how would they kind of cope with that? Would Sometimes it's also helpful to think of a plan of what they might do if they have a mutation positive. Who will they speak to? How will they access support? Does that kind of make sense at all?
Yes, ma'am, it does. It does.
Yeah, because it sounds like he was going through a lot. And I feel like from what you've explained to me, if we were to tell him that, yes, in one way we find a reason for his cancer diagnosis, but that your sister and your daughter is also at risk of having the same mutation, and he's already feeling so depressed and vulnerable, which you recognized. So maybe sometimes we can think of, do we need to give them some time to digest this information and to prepare of a mutation positive result? Now I recognize the urgency of this. I don't know if you all have an option to store DNA sample over there in the abstract lab, because sometimes what we do is, if we feel like someone is not really prepared to have a genetic test, or they may not deal well with a mutation positive result at the time, and if they're willing to give it some thought and take some time to think about it, we sometimes take a DNA sample to store it and then have another discussion, say in a month or two, to have a second pre-test and then kind of see how they're coping with the information we've given them. But I don't know if that's
Yeah,
physically.
so we can biobank the sample and the decision for test. For many times for children, when they are being tested for their parents, you biobank the sample,
Yeah,
and otherwise also. And later on, we if testing is required, we take that out and do that.
yeah,
So consent, biobanking, along with consent that if required, there will be
yeah,
genetic testing. That
yeah,
is
yeah. So
okay.
maybe that's something that you
Yeah.
can think about, if that's an option, for future cases
So
where you might feel they're not really prepared to cope with a mutation positive result at that time.
So I'll just add one more thing, ask you, Aloysius. So you saw this patient in the ward,
Yes,
inpatient.
sir.
So first of
Yes,
all,
sir.
that environment is not in your control. In the genetics clinic, you control the environment when you're doing. So in the ward, when you're doing the genetic counseling, someone might come with a food tray, or the nurse might come for this thing. So that is one thing. But okay, let us assume that everything went uninterrupted and your privacy was maintained and everything else was there and you were sitting. And of course, you may not have a desk to write down. After all this has happened, you got to know about this. Is there someone else in the ward with whom you can speak and get a greater insight about this person than what you have got in that 1 hour's interaction? And he's been in the ward for, let us assume, 10 days.
So interacting with maybe their treating doctor, their medical oncologist over there could give an insight of what is his further immediate treatment plan.
That
So
you can
get
find out from the diagnosis stage, histology, that anyone else who would actually who's not a genetic counselor but may know a lot more than what the genetic counselor has understood about this person, and the family in that 1 hour session. So I want all of you
Really?
to think, and maybe one of you can answer. Who's that person?
So maybe
Is
the
that
nurse who is on call
not maybe the nurse? Okay, the nurses not only talk, they listen to patients. Okay, they talk amongst themselves. They are as concerned about patients' welfare as anyone else. Doctors will come on rounds, take, if they spend 3 hours in the ward, they will spend maybe 10, 15 minutes with each patient. The nurse would see the patient, not only the patient, their family members will go and talk to the nurse will talk to them. So she understands a lot of things that you would not have. So do not underestimate. Ideally, in many setups, so each for each patient there's one nurse, unless until in the daytime. Of course, in the night time, nurses look after more patients, so that nurse would be there. So please, especially when, of course, everything went fine, that may be okay. You didn't spend time just to say hello. So who's the nurse for this patient? In a patient who has a lot of physical symptoms, he's showing emotions, he's showing distress. Not speaking to the nurse is really not a nice thing. You'll be surprised how many things a nurse would have told you about this patient. That in that 1 hour interaction you would not have come to know. So that is one aspect. The second thing is you're working in a multi-speciality hospital. Okay. It is not there in your private clinic. Someone comes and you see them and then they go after you talk to them. This gentleman is admitted in a big hospital where there are all specialties. So what else can you do? And you have sensed that he has distress. And the doctor is the least important person, let me tell you. You might think that doctor knows. Of course, doctors know for this cancer, this stage, this should be the treatment. Whether it's what is kidney function test, liver function test, whether I can give this drug or not that. They're also important. The doctor's notes and this thing will be summarized in the electronic medical records. So
Uh, like referring him to a
before
clinical
that,
psych.
let me talk about the importance of nurse. See, when we work in the most genetic counselors work in the outpatient basis, the nurses are not there. Okay, only occasionally we go and see the patient. So some genetic counselors do not appreciate the huge role of nurses, of your nursing colleagues, and how much they know about the patients and the families. Oh, okay. Just now remember, incidentally, we also have a nurse in this Robini. Is she there today? She was there. No, Robini is not there. In the beginning, she had joined. I think she's probably dropped her. So, Areeba, in the UK, if you have to see a patient in the ward, can you go and see without the nurse or without talking to the nurse?
More often than not, especially in the breast care or colorectal team,
Yeah,
less in the colorectal, more in the breast team, we do get referrals directly from the breast care nurses rather than the doctors.
yeah,
And especially if it's someone who's going through treatment, we liaise quite a bit with the nurses to kind of get samples to understand what's going on with the patient. Is there any issues? I have personally been only to see one patient in the ward so far, and I did not really speak to the nurses because it was not really needed at the time. We had quite a bit of information for her in the referral itself, how she's feeling, how she's doing, her housing situation, everything. But absolutely, if and I don't know, can you access other healthcare notes on your system through TMH files now? Like, can you look at the records? Because sometimes looking at notes as well is helpful. Um, for me, it was helpful to know she's already going through counseling. So I knew there was already a referral for her for counseling support and things. But I'm not sure if you can do that with TMH. But like Sir said, when you work in a multidisciplinary hospital, you must make the most of it. And sometimes, even like for although the previous case was not a ward patient, but I think in both the cases we recognized that it may have been helpful to signpost them for further counseling support. So yeah, so I think that is something that, we all can be mindful of is after this, is there any other support that my patient needs? Because over here my genetic counseling testing has ended, but what about the next steps for this patient? So sometimes we have to be mindful of those things as well, like like Sir has said. And also nurses, like they do, they come to you in the middle of the night when you're in the hospital, and if you're struggling with something, they will talk to you about things, they will talk to your family. So they do know quite a bit from a social care perspective rather than your own treating doctor, because they will come, they will do their ward rounds, they will maybe spend 5 minutes in the room, and they will be out of that. But nurses are really, they're round the clock there for you, and they see a lot that's happening, and sometimes they can tell you whether this patient is not feeling so well mentally, even if they're portraying a very positive mindset when you speak to them, because they may not show that in that 1 hour that you speak to them, or they may not give you that catching points. So having that background through a nurse just before going to the session can also inform you kind of what you need to ask. So yes, definitely.
That
Yeah.
is an important point. And plus, when nurses, when they shift, change duties, they have a very elaborate handover. Especially if there's any concern with any patient, they will always tell the next nurse who will be joining the duty in the night shift or the morning shift. So they know a lot. So use what their knowledge and insight that they have about that person, that patient, the family, the concerns, everything you should, and any conflicts if there are there, they will know also that. So that is there. And some of the notes are there on the electronic medical records, but suppose the patient has been referred for psychological counseling, it may only have been in the nurse's notes. All the nurse's notes do not come in the main electronic health records, or sometimes the counselor or the psychological counseling session, again, everything is not put in the electrical. They would have their own. So if that has happened, maybe for all you know, this patient has already been referred or has been seen in the ward for that. So then you will have to speak with that person and figure out, and you will know a lot. So I think that's my only comment for this case.
Right. How much time do we have today with time? Like how much time are we wanting to spend on this session today? So then we can kind of
We can
um
have maybe one more case. Who else is there presenting amongst you all?
Pooja, I will be presenting the next case.
Okay.
So,
Acha, Robini, you were there? Robini.
Yes, sir, I'm here. I'm here. Hello.
I didn't see you. So, as a nurse, maybe tell them, sometimes people don't appreciate genetic counselor. How much nurses know about patients and their families who are admitted in the ward?
So, as a nursing officer in armed forces, they actually listen to the nursing officers there. I
Oh,
have never had a situation where I am telling them something and they are not listening to me,
okay.
especially when it comes about the chemotherapy instructions or the post chemotherapy
No,
instructions.
no,
I have
I'm
never
not
done
talking
gen.
about not talking about that. So the question
So,
is
as a
that
gen.
the patient is admitted. I think you that time you had logged out. So patient is admitted in the ward. Patient is serious. A lot of concerns. When the
Yes,
genetic
sir.
counselor goes to the ward, they should one of the person they should also speak with is the nurse who's looking after that patient, and
Yes, sir.
you might get a lot of insight which your 1 hour counseling session may not be there. Okay.
Yes, sir. Nurses might tell us about the situation which they have seen in the ward, about the patient situations, patients' perspectives, and
Mhm.
their patients' relatives' perspectives.
Yeah, from all those aspects. Okay. So I think just one more Puja. Areeba, are you okay with time? We can spend 15-20 minutes more.
yes, absolutely.
yes.
Yeah. Right.
So hello, Areeba ma'am. I'm Pooja Rasar. I'm in batch 2 for means this course, genetic counseling, cancer genetic counseling course. So is my screen visible?
Yes, it is.
Yes. Okay. So this was
So
the
let me just say,
case.
all of them are busy preparing their logbook. So they are showing their logbook reflective essay cases. By
Yeah.
next week, they have to submit 50 cases, of which 50 plus 5 reflective cases.
Yes. So this was
Like doing the BGCI certification.
No,
I
this
did
is
not
not for
get it.
BGCI. This
No, no,
is
but
for
I'm saying
us.
it's like along with this, they can use these for their certification as well if they want it.
Yeah, yeah.
Yes. So this was a case which means like after joining the case in 1 or 2 week only I had this encounter with this case. There was a 54-year-old female who was presented with CA breast, and while discussing with her, she mentioned about that her father also had the history. She came with her husband for the before taking the appointment. Like we have this time where we discuss the implication of testing, the benefits of testing, and why this testing is benefited or referred to them. So during that time, they did not mention anything about their children or family as such. And based on their cancer related history, she was diagnosed with triple negative breast cancer and was referred by the doctor for the counseling session, genetic testing. Then she was undergoing the chemo and then was being referred, assessed for the surgery. They mentioned everything. The couple was there for the pre-test inquiry. And post that, the appointment was given on a day where we had the counseling session. Okay. So during the counseling session, a brief history was taken and everything was taken. During the pedigree charting, she mentioned that she had lost two of her children. So one of a 32-year-old male, he died because of cancer, and she had one
No,
girl
not
child.
cancer, cardiac
Sorry,
arrest.
cardiac arrest. Sorry, and a
Son,
girl child. She died because of suicide.
daughter.
A daughter. So she died
What do
because
you
of
say? Died because of suicide?
suicide. Yes. So this was means pointed out by sir also. We should not write committed or because earlier it was a taboo that committing means a crime. So we should write died by suicide or due to suicide, like that.
Even now, there is a taboo that societal attitude has not changed. Even the
Yes.
laws have not changed. Okay. So, committed suicide. In UK, this term, you all use the term committed suicide or it is discouraged?
We normally write death by suicide or
Death
suicidal
by.
death.
Yeah.
So when I was talking to them, the proband, the lady, she was not talking much during discussing the family. The information was given by her husband related to the family, and like whenever they were talking about their daughter and son, they showed that emotional burden in them. So I did ask them if they want to pause the session and they want to come on some other day, but they were like, no, we are fine. So a time was given to them to process their emotion, and then the session was continued. So the major psychosocial aspect which was highlighted, that when I was talking to her alone after her husband, after a detailed counseling session was done, the genetic aspects are discussed. After her husband was waiting outside, I talked to the proband. She started crying and she mentioned that there was a grief, and she was processing the death of her children, and she feels helpless. And she apart from that, the other major concern for her, that she is not able to take care of her husband. He is also old and he is also having health conditions, so she is not able to give as much of time to him because of her ongoing treatment. So these were the highlights or psychosocial concerns expressed by the proband. And later, the genetic counseling session was the implications of genetic testing. The process was discussed. They were agreed. They even mentioned that it is a helpful test it for them also and for their family members as well, as she has other three sisters and brother also. So with that intent, they opted for the testing. And secondly, due to the treatment perspective, they opted for this genetic testing. Post that, the major challenges during the counseling was for me to the managing the unresolved grief they while discussing the cancer is. Secondly, balancing their medical information as well as the emotional sensitivity. And lastly, whenever like I used before this, I used to have the habit of discussing that your children might get this disease, so that is important. But in her case, the major point was, as she doesn't have the children, that was the difficult part to how to address that concern. So addressing the cascade testing was a bit difficult for me, addressing that point. But I should be very, means I was very thoughtful, and I was using the words with limited, means limited addressing by their family members like sister and brother. And post the genetic counseling testing, we identify a BRCA2 variation in her, and the detailed risk management plan was discussed with her. This post-test counseling session was done by a senior genetic counselor. In that time, also, both of them were present for the counseling session. All the options were discussed, for the management plan was discussed. And that time also, the cascade testing was carefully discussed with her and her husband in view of their blood relatives, as in brothers and sisters. So this the reflection for me as a genetic counselor, that not only testing interpretation is important, but emotional support, and the person, how they are presented to you, with what emotional status they are presented, that is very important before proceeding to any session. Secondly, after the counseling, after the genetic testing result, what implications are there in their family, that should be also handled very carefully. And lastly, based on her emotional burden and the ongoing medical concerns, what can we, means how we have to be very sure that they are addressing, means they are complying to that also, and they are taking care of themselves as well, emotionally as well as with respect to the medical journey.
Yeah. Um, Thank you. This is a very,
Just show the pedigree, just bring the pedigree. I just add one thing. After that, Ariba, you can take over. So when this incidents happened, okay, so the son who died who died of a cardiac arrest, and the daughter who died this thing, and I presume the daughter does not have any children,
No,
does
no,
not left behind children. Okay,
no, sir.
so sometimes the burden of looking after the grandchild also comes on this lady. Okay, so that I
Yes.
assume. So which happened? Has it happened 3 months ago? Has it happened 10 years ago? Has it happened? So of course they say things heal with time. Some things never heal with time, but the acute pain
Yes.
and which phase of grief they are. So it is, of course, we are not discussing the grief counseling and all that. So it's a complicated grief. What phase it is very important. So today you are talking of, let us say, February 2026. When did this happen? Okay, you don't have to ask them the date, because if you ask them the date, that itself can bring a lot of
Hmm.
trauma. So,
Yes,
but
sir.
generally, while talking or sometime they might say this happened 2 years ago, or since
Yeah.
5 years this happened.
Yeah.
So that kind of information would help you to understand, have better insight. You would not sort of probe into it, but some information or some idea which you can get through your, during the conversation, that would help.
Yes. So in this case, they mentioned that the son, he was passed away a year before, and the daughter, she passed away within the 6 months.
Within,
Means, yeah,
okay.
yeah,
So all that happened. So it has
like
happened,
one and one half
quick
year.
succession,
Yeah.
just basically one after the other.
Yeah.
Okay. And then you don't have to again ask it.
Yes.
That is what a lot of people
Yes.
would do. Try to interrogate why their daughter died by suicide.
Yeah.
Okay. And it is, it is very natural. The mother would have thought. Sometimes the mother would have guilt, maybe I did not do this,
Yeah.
or I could have done that. I have another patient, I'll just sort of digress from here. I know her, I treated her, she has breast cancer, she has again BRCA2 mutation. She has a daughter, another daughter. She basically died by suicide, she had death by suicide. And then she was narrating, she had so much emotion. Maybe after that happened 4 or 5 years ago. And the other daughter, who's also a carrier, she is not, dilly-dallying, not doing her screening and all. And this lady, proband, she worries about her other daughter. And when she, while talking, she said that this happened to my elder daughter who died by suicide, and what happened. So she opened up after many sessions, and I know her quite well. So you don't have to sort of press it. You give them time, maybe in multiple session, and sometimes what happens, because that thing they have not processed, or that they are, maybe sometimes they are blaming themselves, or she's worrying about her other daughter might also go through, all this. So dealing with this is a very sensitive issue. You give them time, but if they do mention something or whatever else, you take a note of it, and that may be helpful for you in her subsequent, counseling, or in the, the others counseling in the family. Yeah.
Thank you, sir. I think you've touched on a very, very important part here, which is, like in previous cases as well,
Mm.
you all have very amazingly been able to recognize the challenges your patients are facing from a mental health perspective. But what have we done about it? And because it's not your role or responsibility to deal with those issues that are being experienced by your patient. At the same time, you want to help them have the correct support to cope with that. So, even in this case, it may have been that, it may have been helpful to signpost her to counseling support or refer her for counseling support. I know that there can be a taboo from, with respect to counseling in India and some communities still, but unless we start talking more and more about it to our patients as an option, I don't think it will get normalized. And sometimes access is also an issue, but there are quite a lot of support groups that you might find if you look at it, or using the TMH counseling, the psychology team. But because it looks like irrespective of her treatment, irrespective of her genetic testing, she is struggling and they are struggling as a couple, and we need to do something about it. And we are not trained to do anything about it, so we refer them to the next person who is trained to do something about it. The one of the things that I kind of wanted to ask Pooja is, when you did the pre-test counseling session, did you, because it's quite challenging, because her result might impact her treatment as well,
Yes.
and so you can't really give it much time for her to be able to think about and weigh her options and come to terms with kind of whether she wants to definitely have testing right now or not. Obviously, I'm sure you helped her make an informed decision, but the
Yes.
timing was just not the best. And sometimes when people are already going through so much, if they have a mutation, to then kind of communicate that to their relatives
Hmm.
can be quite challenging as well. So did you at all have the chance to explore whether her family knew about her cancer diagnosis, whether she had talked to anybody about genetic testing, how her family might feel, if she was found to have a mutation? Was that explored at all?
So yes, ma'am. So I had asked her if she has been she did disclose this news to her family member.
Mm.
So she mentioned that the cancer related news has been disclosed to her siblings and even her husband's in-laws as well, and they are
Mm.
very supportive. Also,
Mm.
they financial also they are asking about, means, providing help, and emotionally also. But I am not sure, means I did not ask specifically about if she has been means, did she mention about genetic testing to her family members.
Mm.
Yeah, so that might we can in future cases I can be sure that all the things I can ask. Yeah.
So the reason that might be helpful sometimes is
Mm.
because if they haven't had that discussion, I sometimes suggest to my patients to consider whether they might want to have a discussion
Mm.
about the genetic testing they're going through with their family before the result is out. Not saying that they should wait to make the decision about testing, but it takes a few weeks for the result to come back. So in that time frame, to just talk to them, their relatives, and say that this is what I've done, because when a result comes back mutation positive, then at that time to have to someone who's going through breast cancer
Mm.
treatment, who's not doing so well emotionally, to then to have to explain to the siblings that this is what genetic testing is, this is what risk is, and this is what I've been found, and you may be at risk. That's a lot of information to pass on at that
Yes.
time. So having those discussions can sometimes help alleviate that. And the second thing, were you able to at all gather from her whether she would want to have a risk-reducing contralateral mastectomy and a mastectomy on the breast that has? Uh, can you? I can't remember the treatment she had. Has she already had surgery, or is she due to
No,
have
no.
surgery?
She was under the chemo. She
Mm.
was taking neoadjuvant therapy and then
Yeah.
was assessed for the surgery.
So, did you at all explore whether she would consider having a I'm not sure kind of where we are still at, with risk reducing mastectomies, and if how much that the uptake there is of BRCA carriers in India at the
So,
moment. But is
yeah,
that something that you explore?
so for her, I'll just tell. So she's already 51. She has a locally advanced breast cancer. So
Mm.
in her case, we tell them that's an option, but we don't for a, suppose she was, 35 and had early breast cancer where we expect her to do well and live long, then we explain to them, and especially if it has not been operated for the first breast. So that is one of the options that we discuss. In her age, we tell them that's an option. And I don't know whether for this patient it was told or not. We explain to them this is an option and the pros and cons, and if she is interested. But as such, she'll be going and meeting a breast surgeon for that. In this
Yeah.
patient, she had, so that is a common scenario that they had a hysterectomy some years ago for whatever reason, uterine
Mm.
bleeding on her. But whether
Mm.
both the ovaries were removed or not, it is not
Not
mentioned.
sure.
So that
Yeah.
is something because she might think I had my uterus and ovaries removed. So that we have to do a little bit of exploration to figure out it has it been documented or not. So like in
Mm.
England, in NHS, you can see all the electronic health records. Here we will see only the records that we have. And
Mm.
sometimes patients don't keep the health records. So although it's not part of reflective assay, but for her long term, if she's cured of her breast cancer, her second biggest risk is ovarian cancers. So that
Yeah.
is, so we actually specify whether we know whether both the ovaries were removed or not.
Yeah.
That is,
So yeah, definitely, keeping in mind their age or even when they're younger, we always caveat that, whether you would be
yeah,
suitable to have the surgery would
yeah,
depend on your breast surgery team, because obviously they look at BMI, they look at smoking history and a lot of different things of whether you will recover from the surgery. But it's always helpful to have that discussion,
yeah,
because so that they can start to think what they might choose and what they might want to do if they have a mutation. Because again, making those decisions after you have a mutation can be quite emotional, and sometimes people can make irrational decisions. So while waiting for the test result, in situations like these where they need the result for treatment purposes, it's always helpful to ask them to, or to get them to think about these things while they're waiting for the result. And also, how it might impact their, when you spoke to her independently, did you have a chance to discuss with her how a genetic test result might impact her marriage at all, or, her relationship with her sibling? That with siblings not that much, but sometimes we can see that from the past, sir has a few patients who've had quite a difficult time with a mutation positive result from their family life. So
yeah.
were you able to discuss that with her at all?
Of course, she was a 54-year-old, so I think, and she's
Yeah.
already married, as a husband.
Yes.
Yeah. So, like, so yeah, so I mean, would
In
that impact
general,
her
I think you're
relationship
talking.
with her husband? Yeah.
Yeah, so like I discussed that it will have
Mm.
impact in her siblings as well. So after post, if the result comes out positive in such cases, they might also have to test it. So she was very means thoughtful, and she mentioned that she will discuss them that with them also. Even after post test counseling, we do provide family letters for them.
No,
So
I'm not
yeah,
talking about risk of the mutation. I'm talking about, like, for example, from a husband's perspective, knowing that your wife has a mutation and there might be a risk of another cancer in the future. You've been through so much. Sometimes people can get overprotective or, be more concerned, or sometimes people might, blame or not want to be so much associated. So kind of the psychosocial aspects of being a mutation carrier and the impact on your partner and that on you. So that is something, because I mean, normally at that age, and when someone has been married for that long, you can
mm,
gauge after speaking to them, and that's fine. But
yeah.
in this situation, they've been through a lot in the recent past, and just adding one more thing, we also want to kind of be mindful about how that might impact her relationship with her biggest support system, what looks like is her husband.
Yeah.
Does that kind of make sense?
Yes, ma'am. So
Yeah.
yeah, like, they were the husband was very supportive. Uh,
Yeah.
yeah, so that has been discussed. So and she mentioned that like her husband is supportive. Even when we talked, I talked to her husband also. He was
Mm.
also kind of like whatever the results will be, he will be there with her. So that
Yeah.
has been expressed by both of them. Yeah.
And what was going through your mind during this session? What were you feeling? What did you think went well, and what did you think? Maybe you felt challenge. You mentioned some challenges that you
Yeah.
felt. So how were you, as a genetic counselor? How were you able to manage your emotions in the session, and kind of what did you actively do to kind of recognize that and not let that interfere?
Yeah. So firstly, the major challenge was like the information was sudden to me also that they are not means that they lost their children. So I am keeping this practice now going forward, that before any questions or any discussions to be done, I am asking about how their childrens are doing. Then I will get a like smaller bits hints from them that what who all are there involved in their family, who are or involved there in decision making process as well. So
Mm.
those kinds of practices I am doing. And secondly, it was a bit for me also uncomfortable to continue the session when they
Mm.
were suddenly very emotional and they were sad about it. So means I will practice on this, that I should not give my emotional, means I should not feel means based on my emotions about them. So I should keep that aside and practice the session.
I think being empathetic
Yeah.
is definitely a part of our profession, and it's fine, and it's okay to feel sad for your patients, with
Yeah.
your patients. Um, but the importance is to recognize that that is how you are feeling, and sometimes what we may do, or what you know especially in earlier on in our career, if we feel uncomfortable, we might say, okay, let's do this later. So
Yeah.
when we give the option of doing something later on, we have to recognize, is it because we are uncomfortable, or is it because the patient needs that additional time and space to think about things? And which, it sounds like you gave them that option, they said no, and you
Hmm.
carried on.
Hmm. Yes.
But so how did you feel when you had to carry on, being, in spite of being uncomfortable? How did you kind of, this is really important, for your colleagues who may be in a similar situation in the future, having to carry on in a session in spite of being uncomfortable, which is why I'm picking on this a bit. I'm sorry to put you on the spot, Pooja,
Yeah.
but I think it'll be really helpful for others to know mentally, what did you kind of say to yourself, or how did you let yourself carry on in spite of being uncomfortable at that point, or feeling sad, or vulnerable yourself at that point?
Yeah, so means I just means suppressed that thought ki
Mm.
they lost their children and I need to focus on her, and the
Mm.
counseling session is done for her, and it's
Mm.
of her use and her benefit. So
Yeah.
that's how I proceeded further.
Yeah. And if she didn't have, treatment implications right away,
Yeah,
like if supposing she came
yeah.
to you 5 years after treatment and this situation would have, come up, would you have done anything differently?
So then I would have stopped or paused for the minute or some time, and then
Mm.
I would have discussed with some colleague or some other people so that my emotional status is also in control. And based on that, I might have asked some other person to take up the case, or I might have discussed the proceeded with the counseling session in a later days or in after I have been emotionally well.
Okay. So I think in those situations, what you can still do if the patient still wants to continue is you can
Mm.
continue the information giving aspect
Yeah.
and give them time to think about it and say, why don't we come back and have another
Yes.
appointment to discuss kind of your motivations? And so you can list down to them what you will discuss in the next appointment, the motivation to have
Mm.
testing, implication for sibling, etc. So that they have that time to think about it and you have some time also to take in the information you've been given without compromising on the care that you're giving your patient at that time, because they then that way they are taking something back with them to think about at least. But this is a very important thing to recognize your emotions. And if at all anyone ever feels that that's it, they cannot continue, it is okay to tell a patient that I'm really sorry. I feel like I need this, it might be helpful to have someone else come in, or is it okay if I call my colleague, or is it okay if we reschedule this appointment for another day? Because what you don't want is then to go into continuing a session when you're not feeling well yourself or not feeling the best, and then ending up crying in front of your patient, or not being able to communicate as effectively. I don't think any of you will be in that situation because I think everyone is very mindful and very strong. But sometimes you never know, there might be a trigger that, that might kind of lead to some situation like that. I had an experience where just before I was seeing a lady, I had a fight with somebody, and there were mean things said to me, and I just couldn't stop myself from crying. So I started the appointment thinking I can get on with it, but I just started crying. So I said to the patient, "I'm sorry, I'm not feeling well today. Can we reschedule this appointment?" And the patient appreciated that and said, "That's fine." So sometimes we are human as well, and it's okay for us to not be okay with something. Yeah.
Yes, ma'am.
I think that's a very important point which you mentioned, Ariba. And I mean, you are upset about something else. Sometimes while listening to patients or the stories, the aspects, some part of it, that sort of we ourselves get emotionally overwhelmed. Okay. So I think in that aspect, of course, when patients are overwhelmed, we take a pause, we get them time to do that. But because you are in the talking mode, okay, you are the one who are sort of showing that. So when that happens, I mean, it is just a momentary. I mean, even I once in, at least few times in a year when I'm listening to some story. I mean, I shouldn't say story, but listening to the conversation and all that, you're emotionally overwhelmed. But sort of you're trained, so it happens for maybe few seconds or maybe a minute, and then you are back and you sort of get a sense that yes, now you are able to think clearly, because not only you have to think clearly, you have to communicate clearly, and through your communication you should not make matters worse. So that is very important. And sometimes I'll tell you one thing, emotional, since you're talking about, we tend to take sides between, in our mind, between the patient and his or her spouse. Only when you know a lot, after some time, you come to know that the story is not as simple, as straightforward as it appeared to you. And see, I mean, in life, we do take sides, I mean, I'm not saying humans should not be judgmental, but in your professional role, if you are judgmental about things for which you should not be judgmental, it will affect your professional efficiency, your fairness, your counseling advice, which could decide what is done, what is not done, and what is acted upon, what is not acted upon. I myself have got it wrong few times. And I see many of my genetic counselors, they get it, wrong. And I mean, it's very well to say we should not have a bias or this thing, but human beings, there can never be a human being without any, you call it bias for lack of better terms, but we have some preconceived notions. And some things go in that direction, this happened, then we say, okay, I know what is happening. Okay. So you never come to that conclusion that I know what is happening. You note down this is happening, but when I say I know what is happening, okay, this man or this wife is like this, or this brother or this child is like this. So you hold on to coming to a conclusion in your mind, and you will see so many times your initial reaction in the first session or first half an hour, later on it, and this will you'll come to know only when they come on second session or pre-test you had this and post-test counseling or someone else comes for cascade testing, then the whole sort of story emerges. So it is, human nature. We tend to do that, but please try to hold on to this discussion. And many times when we have talked to the other person, like when we talk to the husband, so we all along we're thinking how horrible this man is, how cruel he is to his wife, and this and that. And in the end, you realize that what is happening. So how this lady is perceiving. So it is all also about perception. Of course, physical abuse is one thing, that is nothing about perception. It is there or not there. But there are many other ways how a person can be tortured or can feel that you are tortured, you're under the heat. So we are not there, as Ariba mentioned. We have a defined role, but in addition to that defined role, what so many things, because in the long conversation that we are happening, most of these patients haven't had that long conversation. We get to know many more things. You should not drawn into things where either this is none of your business or you cannot help, and in the process you are deviating from your main role. Okay. And do not have perception, because once you start thinking, oh, this man is not good, or how he's treating her, then because that also a person, like she mentioned, I mean, husband may not be a blood relative, but he's also a person. He also is going through the cancer journey of his wife. He also has gone through the cancer journey of his daughter who had cancer. So that is my only point. So take a very long time before you come to a conclusion. Best is do not come to a conclusion about people.
Yes, sir.
Ariba, have you ever experienced that?
Um, I think I've experienced that with one of my patients where just, this was when I was the first patient I saw who, in their GP notes was mentioned that they had a history of suicidal ideation. And I think, made a preconceived notion that this patient is not going to be able to cope with a genetic mutation positive result. And I think when I went into the clinic in the appointment, I was asking all sorts of questions. I was feeling very uncomfortable because it's the first time I'm speaking to someone who's had that, kind of history of depression and suicidal ideation. And I think he had also attempted suicide at some point. But in spite of all of that, I don't think with the questions I asked, he did give me all the clear answers as to what the test involves, what his risk is, what his management options are, why he wants to have the test. He's clear that he wants to have the test, and um, but he also was in a way kind of in denial, like he was hoping for a mutation negative result. So
Okay.
there was a lot happening, but I think he was making an informed decision about testing, because hoping for a negative result is not the same as not making an informed decision. So I think after reflecting on that case, I've learned quite a bit about not going in with a preconceived notion about someone who has, history of mental health concerns. Um, but I think what I'm taking back from today's case is obviously there's a lot more to our patients than just cancer genetics and testing. And as professionals, you all are, have shown you are capable of recognizing when someone is going through a difficult time. But what I want to leave you with is to find out when there is a patient, you need to refer for bereavement counseling, grief counseling, psychological counseling. Who are you going to refer them to, and how approachable that team is or that person is, and what support groups are there, if there are any, to support people who can't afford counseling, and see kind of how you might incorporate that aspect into your practice. Because what we don't want is, we recognize this aspect of a patient, but then we're not doing anything about it. So that's kind of defeating the purpose. And I understand that there may be limitations of professionals around you who you can signpost or refer to, or options. So just find out and make a list of a department together. These are the options we have to refer patients to places when we recognize this is the need.
So the good thing is now we have a critical mass of genetic counselors training, some with 1 year experience, some with 2 years, some with 3 years, 4 years. Now we have uh, nine of from this batch and seven from the previous batch who are still working with us in various sort of capacities. So I think talking to each other is very important. I think that is one point, and people are from different background, people have different experiences, and we learn a lot from our patients, so that they might help validate some things or suggest a different approach, that would be very useful. And always remember, you are working in the genetics clinic only, you are there with the patient, but you are in a large hospital or a healthcare system. You are not alone. You don't have to take care of the entire all the problems in this world. You see that you do your job well, and whatever else is required, if you have uncovered during your counseling session, that is also provided, and you can guide the patient. And you cannot just write a referral note, you have to talk to the patient. Okay, so you see whether they are comfortable. That part I want to say that. And then before we end, anyone else who hasn't spoken anything, Sharmishta, you want to say a few words about what you understood, gathered, or your one by one. This batch I'll ask.
Yes.
Sharmishta? Hmm.
Yes, first regarding the inpatient ward counseling,
Yeah.
like you said, apart from the family members, the people who are in the ward, the medical staff, plays
Hmm.
a very important role. Like in my time when I was in pediatrics,
Hmm.
so there, the like what exactly is happening with the family, the crucial information sometimes the parents will not provide, because obviously we are meeting them for the first time, they are also under a lot of pressure and under a lot of stress. So the nurses used to help me a lot,
Oh.
telling me what exactly is going on.
So you
uh,
are confirming that the role of nurses, not
yes.
don't ignore them.
Yes, it is very important. Apart from that, going through the EMR before the counseling, before the pre-test counseling is very important. For example, if a person has already referred to a psychologist, so we know it basically helps us to prepare for the session.
Yeah.
What exactly we have to talk to the person, and how should we go about it?
Yeah.
Yes, sir.
Thank you. Ipsita, you have anything to say?
Yes, so first of all, thank you, Ariba ma'am, for highlighting and touching upon a lot of points that you have mentioned. And so, from my end, like I wanted to here indicate that generally coming from the counseling field, like when I do a session, I'm learning the genetics part of it, but I always try to like inculcate some part of like, okay, like I mean, understanding their point of view, and then like crafting the situation accordingly, because that is what also I have learned here, which was very different in the earlier counseling sessions that I used to do. And here, when we do a testing counseling session, we take the pedigree and then we know that okay, what kind of scenario they are coming from, and accordingly like crafting the strategy, like how. And sometimes in my personal experience, I have seen also that in the EMR it would have mentioned that there is no family history of cancer, and they sometimes ended up telling actually, because and sometimes other lot of familial cancers also come into
Yeah.
the picture. And that sometimes has indicated me that how actually talking to them with a lot of empathy and listening to them, it actually helps in revealing and obtaining also a lot of information that is very important for our testing. So
Good.
suddenly when they come, they are somewhat different. And then gradually when the shift happens, I also learn like, okay, how to learn what those elements are and how we can incorporate more of them so that it can help us, sir. Yeah.
Okay. Good points. Anamika,
Uh, Thank you, ma'am, for your session. It was really indeed nice, and I learned few things. First was that, like you said, to not give false hopes. So it's a human instinct that we, as soon as we hear something, to give them reassurance to know it will get better. So to not give that, and always ask the patients in front of you what is the motivation for the testing. And lastly, when you're overwhelmed, surely we do get overwhelmed very soon in a day or somewhere, and obviously, according to our health as well. So to take care of ourselves, and only when you're doing well, we should go ahead with the pre-test counseling or the post-test counseling.
very good.
So
Good. Thank you. Soumya,
Yes, sir. Ma'am, thank you so much for the session. I agree with what Anamika said that we do get overwhelmed sometimes. And I feel what really helps me is that as soon as I step out of the clinic for at least 30 minutes, I must not think about the clinic at all. I think that really helps me. And then, after that, I can think about, oh, maybe this I should have done with the patient, or this is the case I need to focus on. But for 30 minutes, I take that time for myself. Apart from that, I really agree with what you said. Uh, you know, Being sure about what a patient's motivation is towards genetic testing, or asking that question right at the end. Because I've seen with some patients, especially with those with who I have communication barriers, maybe they speak a different language or they don't fully understand the language I'm speaking. With those patients, if they are, visiting me with a relative, they tend to, just go with the flow. And if their relative says, yeah, I understand, the patient is also immediately is like, yeah, I also understood. And it's easy for them to just say that, but maybe they didn't actually understand. And so that's where the whole recall method and asking them, what the motivation for testing is, helps.
good. So Aloysius and Fatma already presented cases, so I won't ask you lack of time. Sankalp,
Hi, sir. For me, coming from a non-genetic counseling or counseling background in general, I had to learn a lot uh, for about talking to people and how people are. I think after sitting in so many sessions, I have learned a lot. And the most important thing that I learned from it was that I can depend on my teammates. I can depend on my
on your
depend
team.
on my teammates,
Hmm.
my
Okay.
batchmates, my seniors. We have a lot of people. For example, Dr. Tarangini. Sometimes I'm like, what
Hmm.
could I have said this patient in this specific situation? And for specifically for pediatric cases, we have Sarmishta, we have Pooja, who have had dealt with many of such cases. So I think depending on people is the most important lesson that I've learned in this.
Thank you, sir. One thing you said you have team members, but during conversation, sometimes you are completely alone. In a deep conversation, like when Fatma narrated the story, in the middle of it. So there's a harm of, it's a very deep conversation, one to one. There's no one there. Okay, you can have it later. So at that point of time, that when there's a flow coming, you would have seen sometimes in the flow of discussion and conversation, so many important things come out. Of course,
Yes.
when you're off, what you call online and offline, at that time, of course, team is there. So, but remember, there'll be times you will feel alone and you are actually alone with that patient and the family. And sometimes not just one person, there are a group of people from that family. So you have to have that, that
Yes,
strength,
sir.
and
Yeah.
that comes from knowledge, skills, and empathy and listening ability. That's all
Yes.
the things.
Yes.
Now, Robini.
Yes, sir. Hello.
Yeah, yeah.
So my main takeaway note for today is whenever the situation goes out of my hand or whenever I'm not well, I should actually reschedule the patient
Yeah,
and call them whenever they are okay. And of course, myself, I'm okay.
yeah. Important point. Very good. Achal, you are listening. Anything you want to say? Have you reached home or on the way?
Sure, I'm on my way right now.
Okay.
But yeah, it was a very informative session. And I agree with all of the points which were mentioned today. And it was a
I'm feeling special in a way that I also, even after being practicing genetic counselor in cancer specifically past 2 years, uh, I really considered that okay, I understand that I need to keep my emotions aside, but I can take a step back and make the question. So that was me. I mean, like, I would like to try if that something happens in that state. But yeah, it was something new that I thought that yes, this is also a way to go ahead.
Yeah. Thank you, Anchal, and thank you for coordinating this with Areeba. So AP with AK, and I think thank you, Areeba. We will catch you more often, and
Definitely.
maybe I'll ask you next week. Their semester exam. I'll ask you to set one question.
Definitely. Sure.
Correct it. Okay.
Okay, sir.
Okay. Thank you very much.
You're welcome. Thank you so much, everyone,
Bye.
and
Bye.
hope all the best for your examinations.
It's a
Bye
good
bye.
2 hour session we had. Thank you.
You're welcome. Thank
Bye.
you.
Bye.
Sir.
Bye.